Good evening, and thank you for attending tonight's Ask the Expert virtual event, where we're going to be talking about fertility, pregnancy, and childbirth. I'm Dr. Jennifer Savitsky, Chair of the Department of Obstetrics and Gynecology at Cleveland Clinic Akron General. And joining me are specialists from Cleveland Clinic's OBGYN and Women's Health Institute. And we're here tonight to answer your questions and provide details on things like how to prepare your body for pregnancy, when to seek help from a fertility specialist, the differences and benefits of childbirth delivery modes, common medical risk factors for a high-risk pregnancy, and of course, questions about COVID-19 vaccine in pregnancy. We had more than 250 submitted questions by our audience. So thank you so much for all of the interest and the questions that you had. We will do our very best to try to answer as many of those questions as we can. We will be sending out an email after the event that includes resources on fertility, pregnancy, and childbirth. So watch out for that. So with that, let's just take a few minutes to do some introductions, and then we will dive right into the questions and answer portion of our event. To kick things off, again, I am Dr. Jennifer Savitsky, and I am the chair of the Department of Obstetrics and Gynecology at Cleveland Clinic Akron General, and I will be tonight's moderator. I am actually coming to you from Lake Canandaigua, New York. So I think that my video is probably the worst of everybody's, but hopefully it will suffice for tonight. I have been a part of the Cleveland Clinic Akron General community since 2001, and I absolutely love working and living in the Southern region as part of the Cleveland Clinic now. And probably one of the most common things that people ask me is just how to be healthy in general in pregnancy. And, you know, the thing that I tell people when they're pregnant or when they're thinking about becoming pregnant is to try to continue to do those habits that we all know are good for our bodies and are also good for us during pregnancy. Things like eating lots of fruits and vegetables, getting adequate amount of sleep, especially while you can before you have that new baby. So I think that a lot of the kind of common sense health related issues are when we're not pregnant, really follow us into pregnancy as well. And that's one of the most common questions that I get. So next on the panel, I'd like to introduce Jennifer Sicardi. She is one of our incredible midwives here within the Women's Health Institute. So Jennifer, tell us a little bit about yourself.
Hi, so my name is Jenny Sicardi. I work at the Cleveland Clinic Hillcrest. I've been with the Cleveland Clinic since 1998 as a labor and delivery nurse, and I worked with some amazing midwives, and so I decided to join the crew. Went back to school and graduated in 2003 with my certificate in nurse midwifery and also a women's health nurse practitioner. Currently, I work mostly out of the Twinsburg location. There are now 13 of us in the East Side practice that deliver at Hillcrest. We are in multiple locations, Solon, Willoughby, Independence, Stephanie Tubbs Jones. At Hillcrest, we have 2 locations. And then we actually do have another, I think, 12 midwives over at Fairview also. So we're a big group practice, and we just, you know, midwifery is its unique little niche, and we love it. So.
Great, thank you, Jenny. Jenny, can you tell us, is there a specific common topic or a common question that you get in your practice?
Yes, so I think the biggest one that I get is, what is a midwife? Or what's the difference between a midwife and a doctor? And so I really specialize in normal pregnancy, normal birth, but also we take care of women throughout the lifespan. We see people early on before their childbearing, during, you know, pregnancy, like I said, and even throughout menopause. We do contraception, infections, period issues, pretty much the whole gamut. But we focus mostly on normal. And that's where the big difference comes in between a midwife and a physician is we keep things very low risk, and our expertise is actually in normal. So when we have somebody and we find a problem happening, maybe their periods aren't a simple fix, or of course a pregnancy that becomes high risk, we have our amazing physician counterparts that help us out. But really, and they do the surgeries. We like to have normal vaginal birth, but sometimes things don't always go that way, and our physicians help. We stay for support, but our physicians step in. So basically, we just focus on normal.
That's awesome. And I think that that's one thing that I've really come to appreciate. Jenny and I have known each other for many years. And, the midwife practice within the Women's Health Institute is really fantastic. And I think the collaboration between the midwives and the OBGYNs is really fantastic to make sure that everybody gets the right type of care at the right time. And to be able to have the options of having midwives. Not all communities have that. So I think that that's fantastic. Wonderful. Thank you, Jenny.
Thank you.
Next with us, we have Dr. Christy Proudfit, and she is a maternal fetal medicine specialist within the Women's Health Institute. Christy?
Yeah. So thank you, Jennifer. I am a maternal fetal medicine staff physician, as you said. I'm also the perinatal quality and safety officer for the Women's Health Institute at the Cleveland Clinic. I've only been here a little less than a year, but I've been in practice for about 11 years. I was at NYU before that. Sort of the opposite of Jenny, I specialize in high-risk pregnancies. And probably the most common question I get asked is what makes a pregnancy high risk? And many, many things. I tend to think about it in different categories. So it could be women who have chronic medical conditions like high blood pressure, diabetes, lupus, cardiac disease. It could be that there's something going on with their baby in this pregnancy. So maybe some sort of birth defect or a baby that's not growing well. It could be that something complicated happened in a previous pregnancy, like preterm birth, for example. Things like multiples fall under me. But also, most women come across a high-risk position during their pregnancy when they have their ultrasounds, because we're also the ultrasound experts. So that's a big part of what we do as well, which means that much of my job is very, very happy.
That's fantastic. And I think that you're absolutely right. It's so wonderful to have the two extremes of the types of care that can be provided between normal and, those types of pregnancies or conditions that require just that extra expertise or specialization that you and your partners provide as well. So it's
I
great.
think often it's a hybrid model that we do,
yes.
right? So I do have midwife patients who come see me and we help out with maybe their gestational diabetes, but it doesn't mean that they still can't see their midwives, for example. So we really love partnering like that.
Yeah, that's fantastic. Fantastic. Wonderful. And finally, we have Dr. Jenna Riemer with us. I love that we have Jennifer, Jenny, and Jenna. I mean, this is a real testament to the popularity of this name in our generation. So Dr. Riemer is a reproductive endocrinology and infertility specialist within the Women's Health Institute.
Yes. Hi. Thanks so much for the introduction. So I was a fellow here at Cleveland Clinic and did my fellowship and training here and stayed on as staff after that. I'm a part of a group of about 6 physicians who specialize in fertility-related care. So we do the full gamut of fertility care, whether that's somebody who's just coming in the door who wants some information about preconception care and trying to figure out like exactly what it is that they need to do to optimize fertility so that their chances of pregnancy happen quickest. Or it might be the couple who's been trying for many years to try to get pregnant without success who walks in our door. We also take care of women who are going through difficult stages in life, dealing with things like cancer, who want to preserve their fertility prior to chemotherapy or radiation treatment, and women who decide to preserve their fertility or freeze their eggs for future use if they know that they're at a stage in their life where they're not ready to start a family, but want to preserve that option for the future. And we also do surgery. So there's a lot of surgical components to reproductive care. So we take care of the full gamut of reproductive medicine.
It's fantastic. Well, thanks so much, Jenna, for being here with us as well. And I'd say let's go ahead and get right into our questions. So again, we received more than 250 questions, including topics like preparing your body for pregnancy, miscarriage, and fertility and aging. So we'll attempt again to answer as many of these questions as we can over the course of about the next 50 minutes. And I'm really excited for the conversation. So the first question that we have goes to Dr. Riemer. And it is, what is the single most valuable thing that you can do when preparing your body for conception?
So I think that this is something that would echo the same answer that most of my colleagues on this call would say, but it is to manage a healthy lifestyle and make sure you're taking a prenatal vitamin. So entering into pregnancy in a state of good health prepares you for a much healthier pregnancy. I tell my patients sometimes that the pregnancy is the great unmasker. If there's anything kind of brewing or underneath the surface, like some issues with some slight high blood pressures or some diabetes that's kind of, creeping into the scene, pregnancy is definitely going to unmask that. So making sure that you're managing those things prior to getting pregnant really sets you up for the most successful and healthy pregnancy. And then a prenatal vitamin should be in the medicine cabinet of every single woman who is trying to get pregnant to get that folic acid on board.
Yeah, that's a great suggestion. Dr. Riemer, can you just speak very briefly about why that folic acid is so important? I think we hear that a lot, but we don't always understand why we should be taking it.
Yeah, exactly. Yeah, the folic acid plays a very essential role in the way the baby is formed, in the DNA synthesis and the role of how things come together. One of the things that can happen when folic acid is depleted in the body and levels are not sufficient enough is that there can be birth defects called neural tube defects. Neural tube defects are where the spine does not come together all the way, whether or not that is along the spinal column or at the level of the brain. And so we want to make sure to prevent those things. And there's a proven way to do that, and that is by supplementing folic acid into your diet. Most of our diet is deficient in folic acid, so taking the prenatal vitamin is making sure that you're getting sufficient levels on a daily basis.
Yeah, that's great. And I think that one of the things that I remember when I was learning about this that really surprised me was how important it is that you have that folic acid supplementation before you even get pregnant. So yeah, I think
I often tell my patients it's called a prenatal, and natal being pregnancy. So we went on pre or before pregnancy happens. I recommend at least 6 weeks before you're thinking about starting to conceive, but even longer is better. So.
Yeah, that's great. That's great advice. Now, kind of segueing into that, I think what you said about trying to, be healthy and to manage those conditions. I get a lot of questions, and I know we got a lot of questions from our audience around kind of medical conditions that somebody might already have, or like what, is there blood work that I should have done? Are there other tests that I should have completed before trying to conceive? Dr. Proudfit, do you have any recommendations on, baseline testing or blood work that should be done? And then also kind of a second part to that question, Dr. Riemer talked about, if you have pre-existing medical conditions, what should women be doing who have these medical conditions that we know can impact or be impacted by pregnancy?
Yeah, great questions. So I think it's really helpful, first of all, to know your blood type. Not everybody knows their blood type, but if you happen to be something negative, which is about 10% of the population, that's just an important thing to know early on in pregnancy, because if you have any bleeding in pregnancy and you are something negative, it's important to speak to your provider because there might be an injection you have to get to try to keep your baby safe in the future. I think making sure your thyroid function is normal. You can check to make sure your immunizations are up to date. So there's blood work we can do to make sure that your immunizations are still effective, because our immunity does wear off. And for some of these things like chickenpox, for example, you really don't want to get that when you're pregnant, but we can't vaccinate you once you're pregnant. I think making sure you're not anemic can be helpful. One thing that most people do once they get pregnant is we talk about genetic carrier screening. So for recessive diseases like sickle cell disease or cystic fibrosis, but there's actually a couple hundred more that we can check for. These are diseases that if you're a carrier, you don't feel any effect from and you don't even know. But if you and your partner happen to be carriers for the same disease, there's about a 25% chance that your baby could be affected with that disease. Again, like I said, most people don't even think about this testing until they're pregnant, but ideally you're able to do the testing before you get pregnant, because if we find out that you are both carriers for the same disease, I can send you over to Dr. Riemer who they can actually go through IVF and they can test embryos to make sure they're not affected with those diseases. Insurance doesn't always cover these tests, especially if you're not pregnant. That's one downside, but it is something to think about. In terms of sort of chronic medical conditions, maternal fetal medicine doctors don't just see people once they're pregnant. We also do preconception consultations. So certainly for women with diabetes, chronic hypertension, lupus, things like that, cardiac disease, we love to see you before you get pregnant so that we can help to optimize things, make sure the medications you're on are safe for use in pregnancy, things like that. Because once you get pregnant, like Dr. Riemer said, it does stress the whole system. There's a lot of changes going on in your body, and it makes it more challenging sometimes to make these adjustments then.
Yeah, that's great advice. I know that when I see patients who have pre-existing medical conditions and they are thinking about getting pregnant, we tend to send those patients to see a maternal fetal medicine specialist just to make sure that they're optimizing every aspect of their health, before they even start trying for pregnancy. And I think sometimes too, there are so many questions that come into play, and to be able to have kind of your mindset at ease to be able to go through those questions with that type of a specialist, I think can be really important. So I really appreciate those types of preconception visits as well. It's great.
Definitely. I also think making sure that your doctors know that you're trying to get pregnant, because that might change some of the choices they make, like with your blood pressure medicine or things like that. That's an important thing.
That's a great point. I think having that conversation, having, that kind of concept of a preconception counseling visit, those are really valuable visits as well. And a lot of times, like even those things that you talked about, getting your blood type done, checking for your immunization status, those are the types of things that can all be done at that preconception counseling visit as well. Yeah. So Jenny, I do have a question for you. And this is around birth control. So I know many women are on birth control before they try to conceive, especially when they're really trying to manage their family planning. What types of advice do you give your patients on how long they should be off birth control to try to conceive? And then when patients have been on birth control for a long period of time, when can they expect that they, potentially are going to get pregnant, or how difficult, is it for patients to get pregnant after having been on birth control?
Yeah, great question. And I do get that one a lot. People go on birth control, you try to avoid pregnancy for, the majority of the start of your life. And then, and now we have a lot more women that are actively managing that and making the choice on when to come off the birth control. So they may have been on for years. So the good news is that it really doesn't matter how long that you've been on birth control, and most women can still get pregnant right away. The biggest decision factor or is what kind of birth control you're on. So there are lots of different types of birth control. Your regular combination birth control pill, the patch, the ring, those are all estrogen and progesterone combination methods. And when you stop those, you can actually get pregnant pretty quickly. Historically, I think providers have told women like between 1 and 3 months, come off your birth control and then try to get pregnant. But you can get pregnant right away. So I generally recommend don't go off until you're ready to start, especially with those estrogen and progesterone combination methods. Now, progesterone only methods, depending on which one you use, they can take just a little bit longer. There's a progesterone only pill, and when you stop that, that's out of your system very quickly, and you can ovulate and get pregnant right away. But now popular things are what we call LARCs, long-acting reversible contraception. So IUDs and the Nexplanon. Those are all implantable devices, and the progesterone lasts for 3, 5. There's a copper IUD that can last for up to 10 years. So they work great when they're in, and when they come out, it may take a cycle, maybe up to 2 or 3 months for it to return to normal. But as soon as you start to have a cycle, you're ovulating and you can get pregnant. So that can be almost immediately. I kind of always put it in the perspective too that, women who've been on birth control pills for many years, and they're like, well, I've been on for so long, it might take a while, so I need to stop and give myself a year. But, you know, if you miss a few pills, people can get pregnant. And so I try to remind them, this is great timing as you're preparing to go off of whatever birth control that you have to start taking prenatal vitamins. And then the only other one that I wanted to mention is Depo-Provera. So the shot that people get for birth control, that one can actually take a little longer to get out of your system. And so, you know, again, if you miss one shot, you can easily get pregnant. But for women who've been on it for longer periods of time, it can take up to a year or more to get pregnant. Now, with that in mind, a lot of people who can't get pregnant right away, you know, are nervous that it was because they were on birth control. But I try to remind people that, you know, even if you were never on anything, it could be difficult to get pregnant. And with that being said, most women can get pregnant spontaneously. As long as you're having a period every month, you're probably able to get pregnant within a few months. But it can actually take up to a year, is considered normal timing, that we wouldn't really be concerned if you don't get pregnant by then. After a year, we refer you to other people like Dr. Riemer.
Fantastic. Thank you, Jenny. Speaking of Dr. Riemer, is it beneficial to test your fertility before even trying to get pregnant? And if so, how do you do that?
That is such a great question. I really like that question. I think that for the overwhelming majority of individuals who are trying to get pregnant, that you don't need to do any type of initial workup or fertility related of seeking labs or evaluation. Now, the things we were talking about to optimize pre-pregnancy, like checking your blood type and your immunizations that we spoke about earlier, those are great things to check in and touch base about. But from the standpoint of saying, like, is there going to be a problem with me getting pregnant? Most of the time, we don't recommend doing an initial workup. Now, there are some patients who right out of the gate should be seeing a fertility specialist. And those would be individuals who know they have problems with ovulation, because if you're not dropping that egg every month, pregnancy can't happen. And one of the key symptoms of not ovulating is not having regular periods. So if you come off of whatever form of contraception or birth control that you were using previously, and you're trying to actively get pregnant, but your periods are not coming in a predictable fashion on a monthly basis, and somewhere between 25 to 35-ish days from one period to the next, if it's anything outside of that range, we would want you to seek care sooner, because that's a key sign that ovulation is not happening like it should. Other things to know are if you have a history of something in the past that might have led to you having issues with fertility. If you had prior treatments or care like chemotherapy or radiation, or prior pelvic surgeries that were extensive that might have led to scars or adhesions. Or if your partner has a history of having surgeries in the testicular region, like a hernia repair or prior injuries, those would be reasons right out of the gate to think about, is there a potential for a fertility problem, and get in with somebody who can talk through those, look at your individual history and the specifics of your story to see whether or not additional testing is warranted early on. But for the majority of people who are actively trying, over 80% will get pregnant within that first year of trying on their own. And so for the majority of the population, we just say continue to track cycles, make sure things are regular, and then give yourself some time. It can take time for pregnancy to happen. The spontaneous pregnancy rate in the general population is only about 20% per month. So only 1 in 5 couples are getting pregnant monthly. So if it's not happening that first or second month, know that that's the norm, and it can take some time. But if it's been, over 6 months, if you're over the age of 35, or up to 12 months if you are under 35, then come see a fertility specialist or start with your OBGYN, somebody who can kind of look at your story and see if additional evaluation is needed.
Yeah, that's fantastic. The next questions, or the set of questions that we received, had to do with fertility and aging. And I kind of want to go between Dr. Riemer and Dr. Proudfoot about these questions. So Dr. Riemer, I'd like to start with you. And that is, you mentioned a little bit about, in a woman over a certain age, if she doesn't get pregnant within 6 months, that perhaps that's a time for them to see a fertility specialist. But what about, like, do you ever see these patients in preconception counseling? Let's say a woman who is approaching 40 years old, has never been pregnant before. We know that women are putting off, even getting into serious relationships, potentially getting married, and definitely putting off childbearing until, for some women, late 30s, even early 40s. What types of things do you talk about with those women when you do have the opportunity to meet with them in a preconception counseling visit?
Absolutely. That's a great segue question into talking about age and fertility. So as women age, our fertility declines. It's just a natural process. We're all born with the same number of eggs that we have. We're born with a set number of eggs, and as we age, those eggs age with us, is what I mean to say. And so as we age, our ovarian reserve and the quality and quantity of our eggs go down. So the closer we get to 40, the harder it is for pregnancy to happen. Spontaneous pregnancies do still happen at that age, and they can, but it makes things a little more challenging. And the time between 40 and 42 is a time where fertility really starts to decline at a more rapid rate than, say, 30 and 32. Mm-hmm. So for a woman who is getting close to 40, we do recommend being seen sooner in that process of fertility seeking care. Because the time window is more narrow, and we don't want to miss an opportunity to kind of jump in and kind of get things going at a faster pace so that the window of fertility doesn't close as quickly on us. The other thing I like to talk to patients about in that age range is really their goals for family planning. So if they're at the age of 39 or 40 and they have always envisioned having a family with 2 or 3 children and they have not started having children yet, it may be a reason to fast track to IVF, because we know by the time they conceive spontaneously and then carry out a pregnancy and are preparing to set up for a second pregnancy, that they may be 41 or 42 at that time. And the opportunity for pregnancy to happen is significantly less than what it was when they were 39 or 40. So we will often have a conversation at my visits talking about, family goals and the size of their family that they're looking for. And if they're in that age range of around 39 or 40 and they know for certain they want 2 or 3 more children, we talk about doing IVF. IVF gives us the opportunity to harvest eggs now at the age that you are, create an embryo and store that embryo in a freezer for future use. And it's kind of locked in time. It allows you to be able to achieve pregnancy at an age where natural fertility may no longer be available, but the uterus will still accept and grow a pregnancy well. So we've locked in time the ability for that pregnancy to happen and for them to complete their family planning goals in the way they desire.
Yeah, that's great. I love that concept that you talked about, thinking about their overall family planning goals. Because I know sometimes we're so fixated on what we want right now, the pregnancy right now, but, the thought of having 2 or 3 kids and where our bodies and our eggs are going to be in 2 or 3 years, obviously it's a big impact of age. So I love that concept of thinking about their family planning goals. So then once a woman does achieve pregnancy, Dr. Proudfit, then we start to talk to you about, or potentially even a woman who hasn't yet achieved pregnancy and who is in their later 30s or maybe even early 40s. What are some of the things that you're talking about with them then, as far as what the impact of our age has on pregnancy?
Right. So, like Dr. Riemer said, just it being harder to get pregnant is the number one thing. But some other things we think about is that egg quality does decline. We do make all the eggs we will ever have before we are ever born. And they start dividing and freeze in time when we're still in our mother's womb. And then every month when we ovulate, some of those eggs sort of wake up and finish dividing. And the longer they've been frozen in time, the more likely they are to make mistakes and divide unequally. And that's where we get abnormal number of chromosomes, which can be things like Down syndrome, which is an extra chromosome 21, but you can have lots of other extra or missing chromosomes, which is the major reason why miscarriage, unfortunately, is also more common in women as we get older. We talk about testing options for Down syndrome and other abnormal numbers of chromosomes. We call that aneuploidy. It's really important to know, though, just because you're 35 or 40, the most likely thing by far is that your baby, if you get especially to a baby with a heartbeat, the most common thing is that your baby has the right number of chromosomes. Your risk is just a little bit elevated, though still generally less than 1%. So we talk about different testing options we have for that. There's some blood tests we can do to pick up over 99% of cases. We have other testing for people who want to know for sure, or if we're seeing signs in early ultrasound that make us concerned, that we can do to test for that. As we get older, all of us tend to be a little unhealthier as well. We're more likely to have hypertension, prediabetes, diabetes, to be a little heavier than we'd like to be. And all of those things, unfortunately, increase the risks of things like preeclampsia, where you get high blood pressure just from the pregnancy itself, gestational diabetes. And then particularly for women who are 40 and older, there's a little bit of an increased risk of stillbirth. So we do some extra ultrasounds and testing near the end of pregnancy. We might recommend that you be delivered by your due date or a week or so before, just to keep your baby safe.
Yeah, that's great. So lots to consider as we're thinking about trying for pregnancy, or even once we are pregnant, when we're in that older age range. One of the things that we laugh about very frequently with our patients, is that the technical diagnosis code that we use in pregnancy once you're 35 years or over is called an elderly gravid, or woman of advanced maternal age. So I never thought we would be considered elderly once we hit 35, but it's one of the wonders of medicine, right? So Jenny, we had a question about the benefits of pelvic floor interventions in helping to influence fertility. Now, it was kind of interesting when I saw that question. I have to admit, I wasn't exactly sure kind of where that was going. I could think of several different avenues, but what are your thoughts about pelvic floor health and pelvic floor interventions when we're thinking about fertility? And then certainly as we think about pregnancy, there's all sorts of, pelvic floor implications as well. So what are your thoughts on that?
Yeah, so actually that was newer to me as well. And I just really learned recently more about it. I use pelvic floor therapy very commonly during pregnancy and postpartum, and in later years, once their childbearing is over. Pelvic floor therapy, so we have specific, it's basically just physical therapy, but they're specialized in the pelvic floor. So women can have issues with that later in life. And fortunately, in midwifery, a lot of our patients, they come to us pregnant. And so I don't have a lot of experience using it with fertility. But when I heard about that recently, I did a little bit more research, and it's really helpful. So basically, it's especially helpful for women who had infertility issues with pelvic adhesions, soft tissue disorders. And so pelvic floor therapy can help to do basically manual or soft tissue, just to help relieve some of the mechanical dysfunction that women have. And so it has been shown to really help optimize and increase your fertility when used. So, if you are trying and you do have a history of having any kind of pelvic floor issues, it would be worth your while to check into this or talk to your OB provider, whether it's your midwife or your physician, and we can get you a referral or consult, because it actually really is helpful.
That's fantastic.
And we do that. We love our pelvic floor therapists.
I know, exactly. We do. I guess going over to Dr. Riemer as well, and I think it's this concept, we know that, like, if somebody has like adhesions within the pelvis, like let's say they have something like endometriosis, and we know there's the risk of there being adhesive disease in the pelvis, the thought of potential interventions to release, those types of adhesions. But Dr. Riemer, do you have any thoughts about, pelvic floor interventions? Is that something that you potentially have had experience with or have made referrals to for that pelvic floor interventions?
I also have not had experience with this either. So I was in the same boat as Jenny, and I plan to do some research and looking into it. So you guys brought a question to us that we're learning from. So I love that. I love when my patients do that. I love when you bring information that you heard about that we can look into to see if there actually is something, because especially in this case, like it sounds like there's some great benefit to doing PT for pelvic adhesions and soft tissue stuff. One other area where I do sometimes refer my patients to physical therapy is some women do have difficulty with intercourse due to the pain of intercourse. And so I have couples who come to me with, infertility, when in reality, it's a timing and frequency of intercourse issue. And there's a lot of pelvic pain associated around that. So I will refer a good number of my patients who come with that specific complaint, if not all my patients who come with that specific complaint, to physical floor therapy, or pelvic floor therapy, sorry. And we also have a chronic pelvic pain clinic here at the Cleveland Clinic as well, too, that is wonderful in helping those patients to overcome some of that pelvic pain. There's also other interventions that we can do from an assisted reproductive technology to help assist with pregnancy happening that doesn't necessarily involve having to undergo or to have intercourse during a season of your life where you're dealing with a flare or a chronic pelvic pain and you still want to achieve that pregnancy. But at the same time, we work synergistically. We work to achieve relieving that pain to ultimately give you a better quality of life in the long haul, even if it maybe isn't exactly how we achieve pregnancy in the short term. So I refer a lot of patients for that reason, but I'm going to now do some research and looking into seeing whether or not PT is helpful for pelvic scars and adhesions also.
That's fantastic. That's a great, and I love it. I love getting these questions as well. It really does help us to grow and expand our expertise also. Dr. Riemer, I did want to ask you one other question, just, thinking about interventions that may not, kind of be the routine interventions that we're used to on a regular basis. And I have to apologize because I know this wasn't in our question list. But how about things like acupuncture or other types of alternative Eastern medicine, or what would be considered alternative medical interventions for infertility? Are there things that you've heard about or things that you might, explore with your patients as well?
Yeah, I get these questions a lot because a lot of patients who are seeking fertility feel very kind of lost and out of control with being able to achieve fertility when they want. And so, and rightly so, and I would be doing the same, but just kind of pulling anything you can from anywhere to try to get some benefit towards getting pregnant. And so exploring all possible options that are out there. I have many patients who bring questions to me about using alternative forms of medicine like acupuncture, massage, these types of things to help achieve pregnancy. We've looked at that a lot in the infertility and fertility research data. So the literature out there is pretty vast, looking at different types of alternative therapies to achieve fertility. And the data is not the best. It's not really supportive of using these alternative methods to achieve pregnancy. Now, what they do show is a reduction in stress. So I always counsel my patients, if you are, at a place where you're feeling a lot of anxiety and stress in your life, which infertility definitely brings on, there's great data out there that shows that a woman with a diagnosis of infertility has the same level of stress as a woman with a recent breast cancer diagnosis. So these women are feeling a significant burden of stress and anxiety in their life. And any of these alternative methods that help reduce that burden of stress, I say go for it. There's no harm in trying to do those things while getting pregnant. There's no harm to your potential pregnancy, but there's not a lot of benefit to help actually achieve pregnancy through them. So if it's going to be bringing, your stress level down and giving you a better quality of life, then absolutely do it. But if you're doing it and it feels like a barrier or a burden, like financially or time commitment wise, don't stress yourself out even more by having to do it, thinking it's going to be the fix all.
Sure. That's really great. I never knew that before about the degree of stress in people going through infertility. I could definitely see where that is true. Kind of on the same, and again, Dr. Proudfit, just going off script just a little bit, kind of the same question to you. Have you had patients come to you and ask you about alternative medical therapies or interventions in dealing with, what would be considered a high-risk pregnancy?
biggest thing actually is acupuncture, most commonly from fertility patients. And I think just like Dr. Riemer said, anything that helps you to feel more relaxed. Pregnancy is a stressful time. No matter how happy you are to be there, even if you worked really hard to be there, it's a lot, and there's all these changes happening to your body. It's a real loss of control. Certainly, just like Dr. Riemer spoke about fertility patients and what a diagnosis of infertility does to your mental health. If I give you a high-risk pregnancy label, there's similar data to suggest that there's significant anxiety and even depression that can come along with that. So I think, self-care, I cannot speak enough about the importance of that during pregnancy because it is a challenging time.
Right, for sure. One of the questions that we did receive kind of goes along with what you're talking about. And the question was, what is the most common misconception about birth or delivery? And quite honestly, from my perspective, one of the most common misconceptions I see is that you're going to lose control, basically. I think we hear a lot of people talk about preferring to do home births or preferring to, or dreading going to the hospital for a delivery because they feel like they're going to lose that control or that we intervene too much. And I think that, you both touched on it, that concept of, whether it's dealing with infertility or dealing with a high-risk pregnancy or even dealing with a normal, completely normal pregnancy, the bottom line is, we tell women all the time, this is your pregnancy. This is your body. You are the expert at what you are going through. And we are here to actually help and to guide you through that process and to help you, manage the information that you're getting and to give you advice on what we know to be true as far as how do you achieve a healthy pregnancy, a healthy mom and healthy baby. And so I think that one of the most common misconceptions is that you will lose that control. Now, to a certain degree, as with anything that happens with our bodies, sometimes things happen that we don't always want to have happen. But I think that entering into a partnership with your doctor or midwife or whoever the person is that's caring for you during your pregnancy, whether that's a specialist, a generalist, or a midwife, it really is a partnership. And I think that, we want to empower our patients as much as possible so that they do feel that control. Jenny, I think that, we see women seek midwifery care because they feel like they're going to have more of that control with you. And I think that's one thing that a lot of the medical professionals, especially in obstetrics, have learned from midwives is to learn how to have that collaborative relationship. How have you been able to foster that collaborative relationship with your patients and help them to feel that sense of control over their own bodies and their own pregnancies?
Yeah. Really it's, I think, mostly about communication and education. Women put out so much trust in their providers. And I think that, a lot of times we tell them what they need to do. And that's super important. There's lots of things we do want them to do. But it's really important for a woman to also have some input on that. And especially when we're talking about birth and, like you said, that empowerment, besides just through the pregnancy, you build that relationship. And, each appointment, I spend more time talking and answering questions than I do actually, listening and measuring to the baby. And so I think it just helps to build their trust in you and the system. As a midwife, I don't feel like I do anything special. I certainly don't have any superpowers that make women go natural and they can do it, except to tell them that. So I think that just kind of building a woman's confidence through their pregnancy that, again, so I specialize in normal and I do a ton of reassurance that, a lot of women have, aches and pains and discomforts, and they're really concerned that, something's going on or something that's wrong. And there's certainly many things that can be, and that's, our job to discern, is it something concerning or not? But most of the time it's just reassurance that those aches and pains are absolutely normal, that, it's common that most women feel these same similar things, and that they're not alone, that their body is doing everything it needs to prepare for this pregnancy and to have them a nice, healthy birth. So in our practice, we do deliver at the hospital. And so that's a service that we can provide, is that we try to keep these low intervention births to, minimize the amount of things people have to do. We do have certain things that we still do. We want to make sure that the baby's okay, but we don't necessarily have to do continuous monitoring if everything is looking good and they're healthy. We need a saline lock, and we check their blood type still, but they don't have to be hooked up. They don't have to be lying in a bed. We see women who have epidurals and who don't have epidurals. We do a lot of natural birth. We support that, but really it's all about the woman having the available resources for those interventions. So being in the hospital, we have our nice little room and we keep it cozy, and we often turn the lights down. Maybe we have some lovely diffusers and smelling and music and all the things. Mm-hmm. But when things don't go quite like they should, again, it's that communication to the patient, making sure that they still have that confidence and reassurance that if we are doing something, making sure they feel like they have a voice and that they understand what or why we feel like we need to do those things. And then right down the hall, if we need any kind of, urgent resources, such as a cesarean birth or a vacuum or forceps, I have physicians right outside the door. And so they can be in a place of comfort and confidence, but still feel like they're safe. There's still anesthesia down the hall. There's still pediatricians down the hall. If anything goes awry, we're safe. But for the majority of our patients, we don't let them in the room. They don't need to come to the room. We have a beautiful birth, and they may never need to see a physician except, with their ultrasound or to maybe do a consent form. But I think the most empowering things for women is just information, communication.
Yeah, I couldn't agree more. That concept of communication is so important. And I think making that space so that patients feel that partnership and feel comfortable being open with their healthcare provider about what they want, about what their concerns are, about what's important to them, during that pregnancy, labor, and delivery process. So that's great. Thank you, Jenny. So Dr. Proudfit, this would not be a panel discussion in 2022 if we did not talk about COVID-19. So I'm not sure how it's probably going to continue to be the top of mind for a lot of people, and certainly rightfully so. Yeah. It's interesting. I have to say, being in New York State, it's been different, the way that we see people interface and interact, even the way some stores are handling still in June of 2020 COVID. But so tell us a little bit about your experience and what you've seen and what you've read about and learned through the pandemic on how does COVID infection affect pregnancy and potentially affect the fetus.
So unfortunately, I have a lot of experience with COVID. I was actually in New York City when COVID started. And at one point, my hospital was entirely COVID, except for labor and delivery and the neonatal intensive care unit. Even then, labor and delivery was a lot of COVID. So I've seen a lot of it. So I've learned a lot. Thankfully, COVID is not a virus that causes birth defects in babies. We don't think it causes miscarriage. So that's all really good news, but it can make mothers very sick. And women are more, initially, we didn't think women who were pregnant were likely to get sicker than the average person. Unfortunately, we know that's not true. Like most infections, COVID is worse if you're pregnant, which makes sense. Your body's already working overtime and, it's supporting another life, maybe more than one, in addition to yours. So if you get really sick when you're pregnant, that in and of itself can increase the risk of preterm birth, but certainly complications for maternal health. Pregnant women who get COVID are more likely to be admitted to the hospital. They're more likely to end up in an intensive care unit. They're more likely to be intubated. So I cannot underscore enough the importance of getting vaccinated for COVID. I know it's an intimidating vaccine for a lot of people, but we have a significant amount of data about the safety of this vaccine in pregnancy. You know, people say, hey, it just makes me nervous. What makes me nervous is a pregnant patient with COVID. Additionally, we can know that COVID affects the placenta. When you look at placentas in moms who've had COVID infection, you can tell it looks like a placenta in a woman who has preeclampsia or other disorders where there's not enough oxygen going to the placenta. There's some data to suggest an increased stillbirth rate. And also maybe an increased risk of babies not growing well. So we do growth ultrasounds for women who've had COVID in pregnancy. Also for women who get the COVID vaccine during pregnancy, some of that immunity you make, we know gets to the baby through the umbilical cord, sort of this passive immunization of the baby. So you can provide your newborn with some protection for COVID at a time when you can't vaccinate them right now.
You know, Dr. Proudfit, we've seen a lot of changes. I mean, and you know, when COVID first started, the recommendations were changing, sometimes literally by the hour. Yes. We know that there are going to be moms out there that have babies when the moms have COVID. Mm-hmm. What is the current recommendation on how that mom should be interfacing with that baby? If she has COVID.
For sure. So, you know, we still really, except if a baby's maybe in a neonatal intensive care unit, so if a baby's extra sick, we're going to be extra cautious there. But in general, we really love keeping moms with babies as much as we can. And the thinking is it's safe. The mother should wear a mask, but it's fine for her to breastfeed. We don't think COVID is transmitted through breast milk. And that, you know, that initial bonding with the baby is so important. And it is thought to be safe. So we really encourage continued rooming in.
That's fantastic. That's great. Dr. Riemer, now as far as fertility goes, what type of information or conversation are you having with your patients around their risk of COVID? Maybe they've had COVID before, or even talking about the COVID vaccine and fertility.
Yeah, so my conversation is very similar to what's already been stated here, that there's lots of evidence and data out there now to show the safety of the vaccine. There's a lot of thoughts about the vaccine as far as like the potential risk, but we're getting more and more data all the time. There was a really well done study that was published that looked at women actually going through IVF and having an embryo transfer who had chosen to get the vaccine versus those that didn't. Pregnancy rates were the same in women who were undergoing an embryo transfer, who had just recently got the vaccine compared to those who had not. So we don't think that it actually impacts fertility in any way. There is some data that shows that you may have a change in your cycle, your menstrual cycle, that first period or even the second period following. And so you may have a slightly shorter or slightly longer period than you would have had if you had not gotten the vaccine. And the thought behind why that is not that it's actually messing with like your fertility or your ovary or your eggs or anything like that, but that your body activated its immune response in response to that vaccine. And so your body underwent a stressful time, right? So many people post-vaccine will have like, a slight fever or feel kind of a little achy. These are common symptoms that happen post-vaccine. And that's your body's way of turning on its immune system and saying, hey, there's a bad guy, there's an invader here. We need to fight this. And so you're going to get an immune response. When you get an immune response, whether it's to a vaccine or to an actual exposure to an organism like a virus or bacteria, your body, when it activates that immune response, says like, hold on a second, maybe now is not the best time for me to kick this egg out. Maybe it's not the best time for me to ovulate right now in the midst of having this very stressful immune thing going on, because it questions the health of ovulating that month. So there's often a little delay. So your cycle can change slightly because of that, but it doesn't have any long-term effects, and cycles go back to normal after that. That's what the data so far that we have is showing. So I don't hesitate at all in counseling my patients towards getting vaccinated who are seeking fertility. And for all of the great reasons that we already talked about, it's safer to be vaccinated than to be unvaccinated if you do become pregnant and were to catch COVID.
Yeah, fantastic. Well, thank you. Thank you both for addressing, that COVID, which is still very much with us. Luckily, our numbers are much, much lower than what they have been in the past 2 years. But I think it's certainly still a concern for many people as they're thinking about or potentially planning to become pregnant. We're going to shift gears just a little bit. We did receive some questions about what we call a primary C-section or requesting a C-section. So I'm going to comment on that just a little bit because I get this question a lot, especially in my duties as chair of the Department of Obstetrics and Gynecology at Cleveland Clinic Akron General. Of course, we're all very concerned about, we want to make sure that we're not doing C-sections unnecessarily. And so some people may have heard the concept of, trying to prevent that first C-section. On the other hand, though, some people actually request C-sections. They may feel that they don't want to put their bodies through a vaginal delivery, or there might be something in their past that they've been through that they don't want to have to go through labor and delivery. There are many countries around the world that really promote the cesarean deliveries over vaginal births for a variety of reasons. There are several countries in South America in particular. But we do get this question quite a bit. And the bottom line is women are able to request a C-section, and we do them in the hospital. One of the things that I think is really important, though, kind of going back to what Jenny talked about, was communicating why. Sometimes the reasons why someone might want a cesarean section, it might be rooted in some misconception or a preconception of something that that we actually have some control over, and we can change for them so that they might be interested in having a vaginal delivery. There are risks to having a cesarean delivery. It is a major abdominal surgery. And especially for people who want to have more than one child, and certainly in people who want to have a larger family, there are significant risks that can happen once you've had multiple C-sections. There are things, sometimes the placenta does not implant appropriately where it should on the uterus in a woman who's had multiple C-sections, and that can significantly risk future pregnancies. So I think for women who might be interested in having a C-section, they just don't want anything to do with vaginal deliveries or birth. I think it's really important to have a conversation with your provider around why you want a C-section and what are your concerns around having a labor and delivery. Because as we said before, there is a lot of things that we can do to try to help support women through their labors. And, certainly we know that there are those risks that are associated with cesarean delivery as well. So Jenny, my next question is for you. And I know that this is kind of we could probably spend a whole session talking about this. And I think that this will probably end up being one of our last questions here. But what are some of the things some of the changes that a woman can expect to experience once she does become pregnant? And then if we have time, maybe we can talk a little bit about after pregnancy as well. I love the concept. Someone once said, it took you 39 weeks to get this way in your pregnancy. It's going to take you 39 weeks to get back. But how do you talk to your patients about the changes that they're going to experience in their body during their pregnancy?
Yeah, so lots and lots and lots of them. So usually, we kind of don't lay it all out right away because it kind of, it's a progress. It's a process in progress. But so many changes happen. So, starting with, as your body is preparing for ovulation, just in general, prior to pregnancy, your body goes through this monthly cycle where your hormones go up and then they go down. And if you don't have a good pregnancy or you don't get pregnant, you have a period, and it just goes over and over again. But as soon as ovulation happens and conception occurs, changes start happening immediately. So we all know about all of the typical things that a woman can anticipate. Your breasts might grow a little bit bigger, get more tender, nauseating first trimester, your uterus grows and swells, but lots of other changes occur too that I think women don't really anticipate. Smooth muscle is just relaxed. There's hormones that slow down your entire GI system. So on top of the nausea and vomiting, you may also have constipation. Your varicose veins and edema, some of that stuff can happen a little bit earlier on for just changes in the smooth muscle. Your lung changes, so people think that they don't get short of breath until the very end of the pregnancy, but in the first trimester, they're huffing and puffing to go down the hall. And that's because you have some changes in your lungs that occur quickly as well. So, cardiac changes, some people will get palpitations, and that can be normal in pregnancy. But I think someone mentioned earlier, pregnancy unmasks everything. And so, if you had never had a heart condition your entire life, and then you start having issues in pregnancy, those can happen because it's so much stress placed on your body. And then, of course, you go through your pregnancy and all those changes continue, except as the pregnancy progresses, the uterus enlarges, and that has much more issues for women as they get into the third trimester, because then we have lots more pelvic discomfort, which is where sometimes we use that pelvic therapy again. The back pain, and then the shortness of breath because you literally have a baby underneath you. The nausea returns because it's pressing up against your stomach. So all of these changes happen, but they don't come on suddenly. Typically, your body will just adapt. And most women have very, very different symptoms. No pregnancy might be the same, let alone each person. Each woman might be totally different, but each pregnancy, I have people on their, third, fourth, fifth baby, and they're like, I've never felt this before. What's wrong? And we're like, well, that's lucky you. And then, of course, childbirth. So childbirth, lots more changes. So many things happen in childbirth. So as your uterus starts to contract, obviously we start to have pain. And that's one of the big fears that people have is, the pain. And so it's so important to sort of prepare. And that's, taking childbirth classes and meditation. And there's so many different things that you can do to kind of like help you cope with the early stage of pain before you get to the point of active labor or pain management, if that's what you're choosing, or how to cope with it if you're not planning any pain medication. But, the uterus contracts and increases in pain, but it's dilating your cervix. And so your cervix literally goes from closed to fully open, fitting a baby out. And then the pelvis adjusts and changes. Obviously, the vaginal tissue will stretch for a vaginal delivery. I won't quite go into the cesarean section. That's a whole nother story. But your body can adapt to it because that's what it was sort of made to do. And then instantly, as soon as this baby comes through the vaginal canal, a lot of those things start to disappear. Now, they don't go away right away, like you said, 40 weeks in, but by 6 weeks, most women are pretty well healed. But immediately after birth, your breasts you've actually started making some milk maybe as early as 16 weeks, but most women don't see it. Some people have leaking prior to delivery, but as soon as the placenta comes out, those hormones kick in and people are like, oh, I don't know if I can make milk. You can. Most likely it's going to be fine, but it doesn't happen until that baby and the placenta comes out. And then, things in the vaginal area, again, pelvic therapy sometimes later on, things. So I specifically said when at 6 weeks, most women are really well healed as opposed to back to normal. So you go back to a non-pregnant state and not a pre-pregnant state. So basically there are some changes, even though things do get back to normal. And obviously without a baby inside of you, everything you may start to ovulate depending on breastfeeding and things like that. But, sometimes the vaginal wall takes some time, exercises that we can do to get that back together. Your cycle may change. I have some people who, were never regular before they got pregnant, and then they're regular, and people have been regular and now they're irregular. And so, we write books on this stuff, but that's part of, I think, the importance of the the prenatal care so that we can sort of, each visit, I give women a chance to say, okay, so what's going on, at this time? What kind of questions do you have? And so they'll tell me whether or not they're having, heartburn or palpitations. And then we talk about anticipation for what the next few weeks will hold. So I think that, prenatal care and seeing your provider is such an important aspect to pregnancy so that we can, again, that communication, education, and hopefully mostly reassurance that everything is okay.
That's awesome.
And referrals if they're not.
Yes, definitely. It's wonderful to have those lifelines and those experts available to us when we need them. But, like you said, Jenny, I think that to be able to communicate through this process, luckily it doesn't just happen, at the snap of a finger. It is a process and something that we can help to guide women through, or at least be there as a lifeline for them or to answer questions when they have them. So. Well, that concludes our Ask the Expert event for this evening. I want to thank Jenny Sicardi, Dr. Jenna Riemer, and Dr. Christy Proudfit for being our incredible panelists today. We will be sending out a post-event email to you in the next day or so with important information about what you just heard, links to all kinds of fertility, pregnancy, childbirth resources, and details on how to make an appointment. If there is something that you would like to talk about, or even just to set up a, kind of well woman or preconception counseling visit. It will also include a link to this recording if you'd like to view it again. So thank you everyone for coming out this evening and joining us here. We hope you have a wonderful evening, and thanks for joining us. Good night.